Hello, my name is Samuel Gill. I am an American College of Sports Medicine personal trainer with a bachelor's in exercise science, and currently I am a master's candidate at Bond University in their Healthcare Innovations program. Safe to say, I am passionate about both healthcare and fitness. So today, I'm here to offer a practical solution for a widespread issue that is being faced by general practice. As GPs, you often face patients with anxiety, depression, or other mental health conditions. You likely already recommend physical activity as part of their recovery, but you may not be comfortable or know the type, the intensity, or the frequency that will actually help. So that's what this session is about. It is about turning general advice into prescription level guidance. By the end of this session, you'll be able to understand ACSM's guidelines for prescribed exercise and mental health, apply the FIT model to create exercise prescriptions, and finally, recognize when to refer to qualified exercise professionals. Let me ask you, have you ever told a patient, try to exercise more? They nodded their head, but didn't follow through. The issue isn't just motivation, it's clarity. Let's take a further look. According to the ACSM's most recent guidelines, here's how to structure exercise programs for people with mental health disorders. For frequency, we're looking for about 3 to 5 days per week of aerobic exercise, and 2 to 3 of those days to include resistance training. For intensity, people with mental health disorders should shoot for moderate intensity. However, higher intensities have been demonstrated to be more effective for younger people. Finally, for type, it can be anything from cycling, walking, body weight exercises, or weight training. All of this applies to patients with depression, anxiety, and even schizophrenia, with a few added considerations like supervision, simplified instructions, and, of course, medication side effects. I know it's unrealistic for you to write full exercise programs, but this is what you can do. Document a specific fit-based prescription in your notes. Refer patients to accredited exercise physiologists or qualified personal trainers. And lastly, you can also use exercise is medicine or integrate referrals into your clinical software. These resources make your job easier and your prescriptions more powerful. Let's take a look at Emma's case.
Emma is a 32-year-old woman living with moderate depression. She's been prescribed SSRIs, but they've only offered limited relief. Low energy and a lack of motivation have made it difficult for her to stay active or engaged in her daily routine. To support her mental health, we've developed a structured exercise program. Just like a medication, but using movement. This includes a 30-minute walk at a moderate pace, 5 days per week, alongside 2 weekly resistance sessions using body weight or resistance bands. The goal here is to build consistency and self-efficacy while also supporting the effects of her medication. Over time, this plan empowers Emma to regain control of her health. One step, one session at a time, anyone can make it happen.
You'll note that her prescription, like any other, has a dosage, frequency, and progression. To wrap up, exercise is a powerful tool in treating mental health conditions. The ACSM FIT model provides a structured, evidence-based way to prescribe it. Lastly, you don't have to be alone. Refer to allied health professionals and use exercises medicine pathways if you need them. Remember, by prescribing exercise with the same care as medication, we not only improve outcomes, we empower patients to take charge of their health. This isn't about becoming a trainer. It's about being better clinicians. Patients trust you. When you speak with specificity and confidence about movement, they listen and they act. Thank you for your time. If you'd like a summary of the video or tools for your practice, check the links in the description below. Take care.
To recap, general practitioners know that exercise can help with mental health, but most don't have the time or training to prescribe it effectively. Often, they default to broad advice which, while well intentioned, lacks the specificity patients need to feel confident to know where to start. Through this education session, I aim to bridge that gap by offering not just a reminder of the benefits of exercise, but a practical tool to make exercise prescribable, as structured and intentional as medication or a referral. In other words, this session doesn't just reaffirm what GPs already value, it helps them take that next clinical step. Adult learners are motivated by relevance, meaning they learn best when they can see how content applies directly to their everyday work. So, instead of framing this session around abstract ideas, I used a case based example that reflects what GPs see in practice. A patient with mild to moderate depression who isn't improving on medication alone. This allows GPs to engage not just intellectually, but empathetically. This structure respects their time and professional autonomy while empowering them with something tangible they can implement right away. I designed this session to build on what GPs already know, not to reteach physiology or exercise science, but to integrate their existing clinical reasoning with a new layer of structure. The FIT model gives a framework for prescribing exercise the same way they'd prescribe pharmacological treatments. It transforms what's often a vague suggestion into a professional recommendation with parameters for frequency, intensity, time, and type. This not only improves patient clarity and compliance, but also strengthens the clinician's confidence in offering movement as medicine. That's the essence of high quality professional education. It activates existing knowledge while filling in the practice gap. The session integrates several core andragogical principles. First, it respects GPs as capable, self-directed learners who bring years of clinical wisdom. It also meets them at a point of readiness. They're already aware of the mental health crisis and are open to the strategies that make their care more effective. Importantly, the learning was problem-centered, not content-centered. Rather than just presenting facts, I presented a situation. How do we give our patients something actionable when they're dealing with anxiety, depression, or other types of mental health conditions? That's what motivates general practitioners. Knowing that they can improve outcomes by doing something differently, something better. Choosing a YouTube format was intentional. GPs are incredibly busy, and expecting synchronous attendance at a training session is often unrealistic. Asynchronous video allows them to engage with the content on their own time, revisit key points, and even share the video with colleagues. Filming in the gym wasn't just about aesthetics. It reinforced that this is practical, real-world content. It breaks the barrier between clinical knowledge and lived experience. And using overlays like the FIT chart helps reinforce those clinical key takeaways visually, supporting retention and encouraging integration into practice. From learning goals to delivery format, every element of this session was intentional. It wasn't about just relaying information, it was about structuring an experience that reflected the way busy clinicians think, learn, and apply new knowledge. Grounded in both adult learning theory and the 6 step procedural framework, the session was designed to move from need recognition to immediate application. It's continuous professional development ready, but more importantly, it's real world ready. And if it results in even one GP prescribing structured exercise more confidently, or one patient experiencing improvement through movement, then the goal of this session has been met. Here are the references I use for this presentation. Once again, thank you for your time.